needed to share with you today.
Thank you so much. Next, we have Matthew Robinson.
Good afternoon, Chairwoman Brown, Chair Bonta, Assemblymember Thurman, Assemblymember Mathis. My name is Matt Robinson. I'm the Legislative Director with the California Association of Health Facilities. And let me just give you a quick background really quick on the California Association of Health Facilities and who we represent. We represent 800 skilled nursing facilities throughout California and 500 intermediate care facilities for developmentally disabled. One of our 15-plus regulators is the Department of Public Health, in addition to CMS, Office of Inspector General, OSHPD, and so forth. But the Department of Public Health is one of our statewide regulators. We're responsible for over 80,000 patient beds in California, and we provide national leading skilled nursing care and several quality indicators to 300,000 patients per year. I mentioned the national leading in quality indicators. These are CMS quality indicators I want to share with you, as some of these numbers have been shared today. We rank number 1 in the country in preventing a decline in activities of daily living. We rank number 1 in the country in preventing depression as well as urinary tract infections. We rank number 2 in the country in preventing weight loss, preventing falls with injury, and use of antipsychotic medications in short-stay residents. We also rank number 4 in the country in controlling pay and long-stay residents. There was also a discussion today about a state mandate for 3.2 nursing hours per patient day. Yes, that is a state mandate, 3.2. Where in fact right now in California, the national average for nurse hours per patient day is 3.73. So CAF has a few recommendations based on what was for the background of this hearing today, and I'd like to share those with you. We look forward and continue to work with the governor, with the legislature, with the department, and help in resolving various issues that were discussed today. Now, we support the governor's proposal to increase CDPH LNC positions to address the outstanding complaints, so long as there are standards set and there is a 60-day maximum limit in closing out and completing complaints and also entity-reported incidents. In addition, CAF hopes to have clear criteria in establishing 2 facilities and defining what is an unusual occurrence as what is defined right now in code. Specifically on the complaint investigations, I'd like to share with you some of the experience that our members have and some thoughts we have in this area. The complaint investigations offer a unique opportunity to identify and correct a substantiated problem in a timely fashion, and a prompt and fully completed investigation benefit all stakeholders. They benefit the family, they benefit the residents, and they also benefit the nursing home. Now, while there are guidelines on when to open an investigation for a complaint or report, as you know, there are no such clear criteria on when that investigation needs to be closed and completed. If a facility did in fact violate a regulation, a deficiency or citation is issued to that facility, and then the facility must provide a plan of correction. Now, unfortunately, CAF members have experienced complaints that are now being investigated, which were opened 2, 3, and even up to 6 years ago. This is troubling and frustrating on various fronts. Number 1, successful investigations and proper enforcement stems from fresh witnesses, substantiated records, and due process. An investigation from 2 to 6 years ago will most likely not have the direct care staff for that resident. The resident may no longer even be at the facility, and a plan of correction is irrelevant and stale at that point in time. Number 2, such delays just elevate anxiety in the residents, elevate anxiety in the family, and elevate anxiety in the facility. Number 3, such a delay is unfair to the residents and families and facilities because facilities must post such deficiencies. Along with, there must be internet postings of this on the HCFS website and also Nursing Home Compare website. So what is currently posted on HCFS or on Nursing Home Compare or what is currently posted in a facility may not be an accurate reflection of what is currently taking place within that facility. Now, CAF, we surveyed a pool of our members to discuss the concerns and thoughts about the backlog of investigations. Of that pool, 60% of our members said that LNC surveyors make multiple visits for the same complaints months apart, thereby creating a staggered investigation. So it may happen 6 months from now, and then they may not come back another 6 months later, thus being a year when they start investigating. 30% of our members who responded to the survey said that LNC turnover makes the complaint process trickle to a new person and the process starts over. You've heard about staff turnover within the department. So once one staff member then opens a complaint, they may leave, and then it goes to another staff member who then must start the whole process over again. Now, the other recommendation I discussed with you was clear criteria for the entity-reported incidents, or the ERIs, as you've seen in your report. Now, the self-reported criteria for unusual occurrences is very vague and it's subjective. There's inconsistent guidelines among the district offices. 99% of our members who responded to that survey said that the most inconsistent self-reported item is a fall with injury. Now, CAF members in multiple locations throughout the state have experienced conflicted information regarding reporting ERIs. We've received conflicting information at our chapter meetings when we've invited the department to speak to this matter, such as there's too much reporting going on or that they should be reporting everything. This inconsistency in these reports just leads to more reports, more investigations, and more time diverted from other important areas. Now, in conclusion, CAF's number one priority is quality of care, and we also support Assemblymembers Brown Bill AB 348 that is dealing with the closing out the complaints. We will continue to be involved with the stakeholder process and assist where we can. Now, CAF is supportive of efficient efforts to address these systemic concerns in tackling these backlog of complaints and investigations, and we hope to have a solid game plan in moving forward in the upcoming years. Thank you.
Thank you. Are there any questions of the panel? Mr. Thurman?
Thank you, Mr. Chair. I want to thank all of the presenters on the panel. It's a really grim outlook when we're having the same conversation from 10 years ago, and we're talking about the same problems and maybe some of the same people. And so I appreciate all of your testimony, and Ms. McGinnis, I appreciate your candor. It was very critical and compelling. I hope I'm not on the other end of any of that. If I'm ever on the other end of that, just call me, okay? But, facts don't lie. And, we have to, as emotional as these issues are, we have to deal with the facts. And you pointed out that basically, with no disrespect to your members, sir, that a lot of companies are making money while the people that we care about suffer. And I appreciate the hardships that those who have done the investigations and, having to make a call while you're reporting somebody. I totally get it, that we have to do better. And I guess the only thing I can ask is why? Why has this been allowed to happen? If we all care about who's in care, we all know that it should be better. Why has this been allowed to be an issue for 10 years or more? I assume it's longer. But why the same conversation for 10 years when we know that people are suffering, that people have illnesses, that people aren't getting good care? Why? I know you have something for us.
I could address that to some respects because I've been involved with trying to get the Department of Public Health licensing and certification to move for a long time, particularly over the last 10 years under the leadership of Dr. Chapman and Kathleen Billingsley. I will say that the department has created management policies and procedures that are absolutely contrary to what you want to do when you want good patient care or you want good oversight or anything else. But most importantly, for the contradictory messages to the district offices, I think that's one of the most important things. Mm-hmm. The nurse evaluators that we talk to that send us information are so disgusted sometimes by their own managers, sometimes by their own supervisors, but particularly from the message from the Department of Public Health here in Sacramento. I will just say that right now, the governor or whoever appoints this person has an opportunity to to help, because Kathleen Billingsley is now gone as well, to create a position where somebody does have the vision and the caring to be able to make sure that they get the oversight that's needed.
What should we be doing? And I know that oversight was our main theme today, but I do agree with the statements from today that with 11,000 complaints outstanding, that if we don't get to a place where we're just focused on quality care, period, it doesn't matter how many investigations that we do, right? We've got to figure out a way to prevent those. Well, so from the standpoint of your association and all of your experience, what are the best practices that we should be doing that will help to prevent the kind of incidents and illness and mistreatment that we heard about today?
Well, number one, I don't know whether it was the Hubbard report or whether it was the auditor who recommended it, but I don't think that we need just nurses to be doing evaluations. I would like to see us go back to the team approach. But I do think we need pharmaceutical consultants. We need social workers. We can use LVNs. We need other ranges of staff who can go out and do those evaluations. I've also been told several times that it's not a matter of not being able to attract nurses to this position, that in fact it's the turnover that's the problem. Nurses get in there, they see what kind of management is there, and they want to get out as soon as possible. So one of the things is to mix up the kind of people who can do these evaluations of nursing homes, including health staff. I mean, I agree. We need people who have some training in healthcare. There's no question about that. But it doesn't have to be an RN.
Thank you. Ms. Cowart, Ms. Boston, anything else so that from your members that they've seen in the field that would allow us to ultimately just improve the overall quality of care?
Well, I agree to a certain point. I think that there does need to be registered nurses to a certain point, because what was described to me when they go out, for example, if you are looking through their medical records, if you don't know medical terminology, if you don't know how to read the charts, and let me tell you, it takes sometimes years of experience to read bad handwriting. So that alone, to know medical terminology and what you think it might say, just that experience alone helps you do your job. And then coming in with the knowledge and skills of appropriate nursing care. If you're talking about, your loved ones, we all want somebody who's at least who's experienced with those kind of skill sets to come in and do evaluations of patient care, because ultimately it is about patient care. Yes. The facility is great. You do want it to be safe, but ultimately it is about patient care and the experience that comes along with those who do the evaluations.
Thank you all for what you do, and thank you, Ms. Brown, for your bill and some
I
of
wanted to just
chair.
follow up on something that she said. You were saying that we have to have you have to read the chart because it's bad handwriting.
Oh, I was just saying that sometimes doctors have very poor handwriting. Sometimes.
But wait a minute. Last time I went
some
to the
members
doctor,
have bad handwriting too. I know.
Some nurses have bad handwriting too.
The last time I went to the doctor, they put everything into a computer. Mm-hmm. You mean we're not doing that?
That's a good question, and I don't have the answer, but I do know. I would think some facilities, if computers go down, and you have to sometimes handwrite orders, and they have to be read. I'm just assuming. But that's a question I can ask.
Thank you very much. Are there any other questions? Yes, Mr. Mathis.
Ms. Boston, you'd stated that there's a gap in between with the state to the county, into the facility and the staff. Can you elaborate on some of the issues that you're talking about with that gap?
I'm sorry, I didn't understand your question.
You had stated that there's issues, for example, between the county with things that are being missed.
Well, I think what I said is the policies and procedures from the state to the county, they differ. They're confusing.
Do you have any examples? That way we can have that in our minds going forward.
Well, some of the examples are the timelines that we have. We'll go out and do things that we're mandated to do, and we found out later that they were not supposed to be done that way. And it gets to be a little confusing, and we miss a lot of our deadlines. But basically, for us and for me out in the field, I found the reason that we are so backlogged is because of the lack of staffing that we have. Our numbers are decreasing as evaluators, and we're not hiring, or when we do hire, it takes so long to train the staff to come in, as has been said. And then when they do come in, some of the staff have left, so you're pretty much evening out the field. You haven't really increased your staffing numbers. So we're forced to do increased work with less staff.
So, in your opinion, would clear guidelines?
Clear guidelines would definitely help the situation.
Okay. Thank you. And then, Mr. Robinson, you'd stated you had agreed with the governor's position and all of that. However, history shows us that the agency has gone and asked for more staff and more money and then turned around and thrown out guidelines. So even if they were to get it, what's to say they're not going to throw that guideline right back out that you're asking for?
Yes. So we're supportive of the governor's proposal in funding those 237 positions, so long as there are guidelines and criteria set. So we would like to see
But
guidelines.
so long as, but the history shows that they've thrown the guidelines out in the past.
We're just trying, to be optimistic in this area, hoping that there will be guidelines and criteria on it, but that is on our wish list for that.
Okay. Thank you, and thank all members of the panel.
Thank you all for your testimony and contributions to today's dialogue. I just wanted to have a follow-up on that question with Mr. Robinson. That was my understanding of your position, that you did generally support the budget augmentation proposed this year, but with some additional guidelines and targets that would be required. It sounded like, Ms. McGinnis, you do not support the budget augmentation, given experience in the past with prior budget augmentations and where that went. I just want to get a better sense, maybe Ms. Coward or Ms. Boston, if you had some views of the budget augmentation, and if I misstated anyone's position, please clarify. We're looking at that in Budget Sub 1. Chairman Thurman, with his leadership, I'm happy to be on that committee. So we're looking for solutions. I think we all agree on the problem here. Please give me your insight and input on this as a possible path forward.
You're talking about the positions in the budget?
The proposed budget augmentations.
Right. So we have never been opposed to that. I think I said in my statement earlier that we was hoping that they would be a majority of health facility evaluator nurses because they do have a backlog, and we think the backlog will continue if something is not put in place, some type of remedy that's sustaining, along with the other suggestions from the HFENs as far as recruitment and retention, and also the training that the state invests in its workforce, but they don't currently have the ability to retain the nurses that they train. So.
Thank you. Do you want to add anything, Ms. Boston?
Just to say that as far as the backlog complaints go, I don't know how long it will take to clear them up. I know personally we work the overtime to try to get the complaints done. We take the complaints home. But because we're inundated with the new complaints, the backlog ones that we do clear up, we get the new ones in and they become backlog. So I don't know what the solution is, except from my point of view, is to hire more staff, to increase the budget for staffing.
Thank you, Ms. Boston. Anyone else on this issue? Okay. Ms. McGinnis?
Well, I do think, number one, as I said before, we don't need to have all nurses, registered nurses. You can use LVNs. You can train LVNs. They work in, most of the staff in nursing homes are LVNs anyway. There are very few registered nurses. Secondly, in terms of the complaints, it's exactly the problem that Mr. Robertson explained, is that we need consistency in the investigation of complaint. You get a complaint, you go out, you investigate it, you complete the investigation within 40 days or 45 days, and bam, you're done. What they do now is, because the staff turnover, because of the management problems in the district offices, is that they'll go send somebody out, they do a drive-by complaint initiation just so that they can meet the mandate of the Superior Court, and then they'll be back 6 months later to do another part of it, and it's somebody else who's doing the investigation. So if once you get the guidelines down, once you have a statutory timeline, And in terms of enforcing that, if they ignore a statutory timeline, we'll go back to court and sue on that issue too. So I think that there's a good chance that they're going to have to do that.
Thank you so much, panel. We really appreciate you. Oh, I'm sorry. Yes.
Just a technical question, Mr. Robinson. You described the various agencies that fall under your association, and you were giving a list of the types of agencies that do the inspections. You mentioned intermediate care facilities, and I was wondering, you mentioned that the Department of Public Health and some other agencies visit. Are they also inspected by community care licensing since they serve people with developmental disabilities?
No. So our intermediate care facilities for the developmentally disabled on who we represent are the DDHs and the DDNs. Those are actually defined as a health facility under Health and Safety Code 1250, and they're in fact regulated by the Department of Public Health. So and they're also reimbursed under the DHCS.
So your ICFs really are not about residential living. They're intermediate care facilities for folks who have a nursing need or another health-related need.
That is correct. And those facilities, sir, they look much like a 6-bedroom home within your neighborhood for those type of needs.
Got it. I didn't hear you say the DDN the first time. You said ICF. I got you. Thank you.
Yes.
One last thing. I just want to be very clear. The type of assessment that's involved in when you go out and evaluate patient care, I don't think is within the scope of license of the LVN. So as we're thinking about, what this looks like, we need to really look at what it entails in becoming a health facility evaluator nurse.
Thank you so much. Thank you again for your wonderful testimony and giving us a glimpse into this subject. Thank you.